The topic is about lengthening. Unfortunately, I'm the last one in the session and I have to finish in 7 minutes only because we have to be on time because other speakers, they are a big time difference, so we cannot wait till the end of the lecture. So I will use only 7 minutes. The topic is limb lengthening. Are we talking about the same patient? The people will talk, all the previous talks were about limb lengthening. But are we talking about the same patient? Are we talking the same language? I don't think so. Everybody is expecting that in the conclusion I'm going to say there is a paradigm shift in the limb lengthening towards lengthening nails. Everybody's expecting, everybody's saying the same thing, but I'm not going to do it. I'm going to repeat the questions. Are we talking about the same patient? I'm going to skip the history because I'm just telling you our history with Lazarov. Our history with limb lengthening started in 1983 in my university, Banha University Hospital, and Professor Kazem, who imported Lazarov, and we started since that date. I think this was the first attempt to do limb lengthening in this area using Lazarov. And since that date, I reported my experience in this paper, and it's, if you wanna have a look on it, to see my experience, 37 years experience with this. Again, I'm going to skip the history. The aim of limb lengthening quality, functional improvements, and cosmetic lengthening. When you see the experience on the internet, most of the people say that they have the greatest experience with limb lengthening. But you look to their profile and their papers, mostly they speak about cosmetic lengthening. Mostly, they speak about cosmetic lengthening. But I want to show you the type of patients I'm talking about to see at the end. Are we speaking the same language or we are speaking two different languages? And this is one of the patients with 180 degrees rotational foot. This is the heel of the foot and this is the patella. So it's rotated 180 degrees with severe shortening and angulation. And this is lengthening and rotational derotation of the foot. So the aim of bone lengthening is not just to put a nail and increase the length of the patient from 1.5 centimeter till 8. The aim of bone lengthening is changing lives. It's not 1.5 centimeter shortening. Again, it seems like we are talking two different languages. Again, the aim of bone lengthening is change the life of the patient from this stage to that stage. Again, you can move your patients from this point to that point with 22 centimeter lengthening and reduction of reducing the malalignment and union. We also speak about cosmetic lengthening for 11 centimeters, it's okay. With this poor lady, you can have also lengthening for 11 centimeters. When we speak about bone lengthening, everybody forgets the law of tension stress. We have to remember all the methods, all the machines, all the hardware, they are based on the law of tension stress or the biologic law of tensor stress. And the stages of bone lengthening, latency period, distraction, and consolidation. There is no change. And the people forget because everybody sick. wants to have the conclusion that there is a paradigm shift towards intramedullary nail, that there are many methods to stimulate the regeneration, systemic and local. They forgot about it. And this is the real revolution. If you want to have a revolution, if you have a dramatic shift, you should have a new biologic solution, not a new instrument, not a new hardware. There is no fancy in the subject. If you want to lengthen for 1.5 centimeter and use an intramedullary nail and you think that this is an achievement, okay. Again, I have to skip many slides because I have only 7 minutes. The indications for limb lengthening are controversial. Again, limb length discrepancy, dwarfism, and the cosmetic lengthening. And as you see here, just a case of fibular hemelia. You can do lengthening and deformity correction at the same time. Can you do acute correction of the deformity in fibular hemelia? You cannot. This is the congenital deformity. And if you want to do something acute, you have to do massive or significant shortening. Look to the complications. I took it from the different papers about limb lengthening. I want to prove one point. Those are 73 patients performed over 14 years old. So if you divide 73 by 14, that means they did about 5 operations per year. So perhaps less than half a patient per month. This paper, 32 patients for 3 years. So 10 patients per year. So less than 1 patient per month. 35 patients over 2 years. 43 patients over 16 years. So 2.5 patients per year. So the experience is they are doing 1 patient every 4 months. Okay. 63 patients over 25 years. Can you imagine? So 2 patients every year, a great experience. And so on and so on and so on. The problem with bone lengthening and talking about bone lengthening, that people are talking about different things. And the people, when they do cosmetic lengthening, they consider themselves an authority to talk about limb lengthening. Limb lengthening in cosmetic lengthening is totally different from limb lengthening in deformity and even deformity. When the people talk about deformity, perhaps again, they are not talking the same language. It looks like this case with non-union of the lower femur. And again, bone transport and lengthening. Premature consolidation of the regenerate. You see the muscles, very strong muscles and infection. And again, the real merit that you can reduce the area of the deformity post-operative in your clinic, in the outpatient clinic, without anesthesia. Again, the people forget the complications of intramedullary nailing. Or they ignore it. Or they report it after 10 years from the patency. I'm going to use some examples of achondroplasia, the way we do it with the poor patients. We do first lengthening at age 5, the second femoral length at age 9, Second, lengthening tibial 11 to 13. We finish at the age 15 before going to the university. As you see, tibial lengthening for 17 centimeters. Femoral lengthening for 13 centimeters. It's not 8 centimeters. It's not 1.5 centimeters. So if you want to compare your results, you have to compare your results with these patients, not the patients you choose. This is humeral lengthening in the same patient. Again, cosmetic lengthening for such a long distance, not 8 centimeters. Upper extremity lengthening. (10 centimeters for the humerus. Forearm lengthening, 115% of the original length. Phalangeal lengthening. The magnitude of lengthening. Do we have a limit, 20%? We don't think so. Look to the case of tibial hemimelia. In the different stages, 10 centimeter lengthening. Another stage. Then correction of the deformity. It's 10 centimeter lengthening, 12 centimeter lengthening. Again, humeral lengthening. 115% of the original length. Do we have a limit, 20%? This is amputated foot. And the microsurgeons decided to excise this part, so they have 22 centimeter shortening, and this was their end result. I didn't do it, somebody else. In Kenya, they did it. And they have this picture. And we had non-union with this deformity also. So corticotomy, lengthening, 12 centimeters, 22 centimeter lengthening. Do you want to put a nail? So when you talk about lengthening, I'm talking about the experience. The role of the surgeon, volume on patient outcome and the complications. The problem, when you have a look on the internet and the people describing themselves, all of them, well, no, not all of them, many of them, they talk about they have great, great experience. We never say so. Again, our experience does not include animation experience, because I've seen many with animation, great animation experience, but with the real load, there's nothing if you compare it. Or the real load is just cosmetic lengthening, and they consider cosmetic lengthening the real experience of lengthening. Unfortunately, we have a huge number of cases. 1/3 of the population is under 15. Victims of conflicts, high incidence of congenital anomalies, high incidence of neglected trauma. So if you talk about experience in limb lengthening, you have to talk about which field. You talk about the advertisement. We don't have this way of experience. Do you call animation experience? Will you just show us the animation and the animation and the animation? Again, remember the complication. Just divide, that in some papers, you find the experience is something like 0.1 patient per year. So limb lengthening is a rapidly developing field of orthopedic surgery. Currently, is a standard procedure with predictable results. Indications have been extended to include upper extremities and cosmetic lengthening. I think experience has a great impact on the results of the different procedures because follow-up and management of expected complications are cornerstone of treatment surgery. Unfortunately, the English literature has many papers with relatively small numbers of patients operated by many surgeons over a long period. This means that the experience of the individual surgeon is based only one or few cases per year. Sometimes it's difficult to get valid conclusions from reported mixed data. In spite of the introduction of promising intramedullary lengthening nails and computer-assisting external fixation, we still count on a lot of biologic laws. And if you want to invent something, you have to find another biologic law or biologic solutions. Advances through the research to stimulate regeneration and reduce the period of treatment will be the rare revolution in limb lengthening surgery. Again, this is my experience if you want to have a look. Finally, I want to tell you something. There is more than one solution for each problem. We are not talking about the same patient. We are not talking about the same patient. Thank you.
Thank you very much, Professor Gamal, for presenting these illustrative lectures and sharing with us his vast experience in limb lengthening.